Hello and welcome to the latest edition of Health on the Line, produced by Health Comms Plus on behalf of the NHS Confederation. Before we get into the content for this episode, you may have seen recently that the Task Force for Diversity in NHS Communications recently published a report into the lack of diversity in NH Comms. The task force is calling on all senior leaders in the NHS to sign a diversity charter committing to inclusive recruitment, development and leadership practices. Please go to the Confed website for further information. Before we get into all things neighbourhood health, I'd like to touch on a topic it's causing real concern with our ICS members. Recent reports in both the Health Service Journal and the Sunday Times on ICB redundancies, coupled with the news that at least one integrated care board has already said it will not progress a redundancy scheme needed to halve its operating costs, over concerns over how that scheme will be funded, well, this all signals turbulent times ahead. With me to discuss this issue is my Confed colleague and Assistant Director of the ICS Network, Ian Perrin. Welcome, Ian. Great to have you on Health on the Line.
Thanks, Matthew. Thanks for having me.
So, for those who don't know the story, it's a bit complicated. So can you tell us the whole story and where it is we find ourselves now?
Yeah, thanks, Matthew. So the story starts back in March this year. NHS England asked integrated care boards to cut their running and programme costs, essentially their operational costs, by 50% on average by the end of December this year. What happened after that was NHS England published a model ICB blueprint, which set out the future role and functions of ICBs. This phrase, strategic commissioning, was the headline ask for ICBs, which is a change from what they've done in the past, and set out some functions that they will continue to do and should do more of, and some functions that they should look to do less of, but will be sought to be transferred through legislation in the future. So things like continuing healthcare, infection prevention and control, safeguarding, etc. The 50% isn't a blanket 50% for all integrated care boards. So some are looking at 25 to 30%. Some are as high as about 2/3. And obviously with such a short time frame, the ambition was to look to do this very quickly. This has caused some conversation about clusters and possible mergers in the future of integrated care boards. So we're looking at the reduction of numbers in integrated care boards from 42 down to around 27. This is all about helping to achieve financial balance and to invest more in the front line for patient-facing services. So where we are in this, in the journey of this kind of issue has been the kind of cost and the numbers of reductions being sought across integrated care boards risks putting them into deficit for this financial year, because it's something that wasn't planned at the start of the financial year in terms of financial planning. So
is that mainly redundancy costs? Yeah.
This is mainly redundancy costs. Yeah. And we're talking for different integrated care boards, hundreds of staff. So in total, thousands, and costs looking up to £50 million we've heard cited with our members, figures in the region of 30 to 40 for others, £1 million. So big cost for integrated care boards, and some have ballparked the kind of total figure at about £1 billion. So really significant, and not something that was forecast at the start of this financial year. What that means is plans for redundancies have to be approved nationally by NHS England and the Treasury. And a conversation with the Treasury happens on whether or not funding can be provided centrally to help cover the costs so that systems can remain in a financial balance for this year. Those processes have been quite slow for this year. So understanding exactly what can be provided centrally and what can't is still an ongoing debate. I understand NHS England are in negotiations with the Treasury at the moment, and the process for signing off redundancies has been stalled. So systems were ready to go with their redundancy schemes in July. Have been really working at pace to form these clusters to figure out how they can deliver the future role within what is available to them, but are waiting really for national teams to to press ahead with this. So our ask and what we've been pushing for nationally has been to speed up the processes as much as possible to allow ICBs to deliver what can be delivered this financial year, and then look to next financial year to deliver what is likely to be the bulk of the redundancy programs, largely because the ability to pay for it within year is slipping away as the year goes on.
Thanks, Ian. So, as is often the case, there's kind of the big issue, but then there's smaller, more kind of specific issues that emerge out of this. So, tell me if I'm right about this. It's intermediate kind of 2 or 3. So, one is that if the money is not provided for those redundancies to be undertaken this year, that will mean that cost goes into the next financial year. And it's already incredibly difficult for ICBs to see how they can get to the £19 per head limit that they've got for next year. So one issue is if you don't do it this year and you don't get the support for this year, then it carries on into the next year. A second issue is the kind of the consultation with staff, because this is covered by employment legislation, by agreed rules around these things, and the timescale means that you can't start that consultation process formally until you know that you've got the money for it, which is another thing that delays things, but also has an enormous impact on staff, because we're talking here, as you say, across the country around thousands of people who've given many, many years to the health service in this kind of terrible limbo. And then the third element, if I get this right, Ian, is that in those ICBs that have been clustered, where obviously there's a change of executive leadership, because, in some you're talking about 3, I think even 4 ICSs, or certainly 3 ICSs coming together. So, there's going to be only 1 chief executive out of 3, etc. The executive redundancy package, which is, probably affordable, has to actually formally be approved by the Treasury, because I think because it's people on higher salaries. And that's just stuck in the bureaucracy of the Treasury. So they can't even undertake the executive redundancy package, without which it's very hard to take the kind of next steps in the process of reorganisation. Is that a fair account, of some of the other kind of particular issues that have dropped out of this?
Yeah, that's absolutely right, Matthew. I remember you used the metaphor a couple of days ago that we sort of suggested that perhaps they were on a roller coaster, and I think they suggested that actually they're not on the roller coaster yet; they're waiting in the queue, because they're not able to yet to press ahead with these schemes and waiting for sign off from the Treasury. So absolutely, that's a big issue. We're also hearing that those ICSs that are clustering, as you say, this is just a much more complicated process for them. So those that are staying the same boundaries with the same population coverage are essentially further ahead in the process, and that means further ahead in the process for becoming strategic commissioners and cracking on with work to deliver the ambitions in the 10-year plan. So there's an element of a staggered start for different ICSs in this process. And as you say, the impact on staff is massive. We've heard reports of from our members of staff sickness rates increasing, anxiety, really high at the moment, as you would expect, and unsurprisingly, really. And then also there's a risk that this process goes over winter, which I think was something that everybody wanted to avoid at the start of this process, and that will, obviously have an impact on delivery of winter plans over the course of the winter. So trying to get some certainty as much as possible now, which is what we've been pressing for, about what the new timelines can look like, what is a realistic ambition to deliver this, so that staff can focus on the challenges right in front of them and come to this stuff as soon as they can.
Yeah, and just to kind of finish, Ian, I think that the longer this goes on, the greater the risks. And I think there are short-term and medium-term risks. The medium-term risk is ICBs are actually very important to the 10-year plan, not just strategic commissioning, but market making. They're critical to brokering, who's going to be the multi-neighbourhood provider. Later on this podcast, we're talking to Andrew Bland, who's done fantastic work in South East London, an ICB that isn't having to cluster at this stage. We want ICBs out there making the 10-year plan happen, but it's difficult to do it when they're in this situation of chaos. But in the immediate term, as you've said, when organisations have important responsibilities, are in this kind of limbo, in this kind of chaos, there are inevitably risks that emerge from that in terms of their capacity to undertake their kind of day-to-day responsibilities. So we can only carry on, Ian, can't we, pressing the centre to be realistic and to be reasonable and to try to resolve these issues, well, now.
Yeah, that's absolutely right, Matthew. And we're working really hard to try and make sure that that happens and to ensure that our members are part of the process as well, so that they can raise these issues as early as possible. And, inevitably questions come up here and there throughout the process, and making sure that there's as much clarity as possible is absolutely crucial to this.
Ian, thanks so much for joining me.
Thank you.
Now, neighbourhood is a major theme in the 10-year plan, as we know. The shift from hospital to community in all senses, the expansion of integrated multi-professional teams working in local communities, often co-located. The aim is to deliver a model of care that's preventative and better supports those most in need, particularly those with long-term conditions. So when Andrew Bland, CEO of South East London ICB, contacted a number of people, but I was one of them, to share the work that he's been doing around neighbourhood health service integrators, I was really eager to hear more and to share that with you, listeners to Health on the Line. And joining Andrew this morning is our own Ruth Rankine, Director of Primary Care, but increasingly now the Confed's kind of neighbourhood guru. Welcome, Andrew and Ruth, to Health on the Line.
Good morning.
Andrew, I want to start with you. I want to get into what you're doing in South East London because I think it's absolutely fascinating. But before we do that, let's just get your take as an ICB CEO, but also with your hat on as Primary Care Transformation Lead for London. What are your thoughts about the 10-year plan and the future it set out for health and care at neighbourhood level? Has it got it right in your view?
Well, thanks for having me, first of all, Matthew, and for responding. I'm keen to tell you about our integrator work. And as regard the plan, broadly speaking, the short answer is yes. You've said it yourself, a sort of proactive, preventative, population-based approach, keeping people well rather than treating them when they're ill. What's to argue with? And Ruth may remember it, but 364 days ago, we started our neighbourhoods programme in London. And one of the explicit tasks there was to try and influence this plan. So we see a lot of alignment. I think it's brought in the right place. Importantly, it speaks to what we thought of as a perfect storm. So we've got wider determinants of health exacerbating people's health conditions. They've turned up in greater number to services that can't treat them, and then the cycle gets worse while we're spending more money than ever. So doing this feels like the only game in town from my point of view, or certainly a big piece of the puzzle. And then I guess the only thing I cheeky say is the name needs a bit of work. So I think David Nicholson said primary care trusts didn't do primary care and no one trusted them. The neighbourhood health sort of neighbourhoods are a bit smaller in my part of the world than 50 or 100,000 people. And health service is absolutely right, but this is health and care. This is about what the NHS can do with its partners. So we've sort of termed the phrase healthy communities, but, I'm dancing on the head of a pin. I think the plan's brought in the right place. I would just say, Matthew, since you invited it, the and, not the buts, is that there's a lot of devil in the details. So I think it proposes some contracts that, if they're not pitched correctly, could take us back as opposed to propel us, but they could propel us. I think there'll be a real expectation of pace and return on investment, but a lot of the stuff we've done in this space has found unmet need and raised activity in the first instance before it's reduced it. So what will be the politics of that? And also, we've got the opportunity to really dial up the sort of what I call the not NHS solutions, the ones with voluntary sector, with housing, with others. We've got the opportunity to do the reverse. It's complicated stuff. And then I read your piece 2 days ago, or a week ago, about sort of the six in a wider context of this plan. This is chapter 2. So if I look at the other chapters, how compatible is this with a chased FTs? FT status or for league tables, if you're an acute trust, is this compatible with a commission provider split where it's putting a lot on contracts and there's a softer side to that? And there's a new world, so who's going to convene it? Well, I've got a bit of a view in London, as you might expect, but I'm not sure the plan gives an explicit view. The final thing I'd just say is that's the context of the plan. So in the real world events, we've got strikes to deal with, we've got other things to deal with. We've had deficit support removed. That means different things in different places. So there's lots to distract us, but I like the plan.
Well, that's fascinating, Andrew, because the points that you identified are very similar to the ones that I came away with when I attended just last week in York, where I live, a session in North Yorkshire and Humber with Claire Fuller and James Kent, and they were coming to talk about neighbourhoods, and there was a lot of positivity, and there's a lot going for neighbourhoods in this neck of the woods, particularly because we have kind of primary at scale. But one point that hit me, which you've touched on, is, well, who's going to be the broker for all of this? You know, it's a voluntaristic system. Nobody is going to be forced into multi-neighbourhoods or to single neighbourhoods. It requires people to come forward. And so where is the brokerage given the kind of challenges that ICBs are facing? And then the second issue is that, you know, we spent most of the day talking about neighbourhoods, but the 10-year plan strategy, the left shift, without which we really don't have a sustainable health service, relies not just on what happens at neighbourhoods, but it relies on the engagement of trusts, and particularly of acute trusts in the conversation. Before Andrew, we get into how you've addressed that in South East London, Ruth, do you share the view that some of the biggest challenges for the vision of neighbourhoods is this question of who's going to kind of broker this, who's going to put the parties together, and how do we make sure that acutes come to the table?
So I think that is an issue, and I think the role of the ICB is absolutely critical in this, not in leading it, but in supporting providers and partners to come together. And I think where we see it working around the country really well, ICBs are in that sort of facilitation role. So they're helping to bring the right people into the right room, helping to facilitate the conversation, and they are there to expose some of those just insurmountable, I guess, challenges, whether they're real or perceived, that people are bringing to the table. So rather than, I guess, people continuing to just avoid some of the difficult problems that are going to get in the way of this, I think this is the time for a really honest conversation about motives and what people are in this for and what people are going to get out of it. And there will have to be compromises along the way. But one of the things that I do worry about is that in some of this, there starts to be a bit of a power struggle as people get fixated on who's going to be the neighbourhood lead. And I think that and some of that is driven by a fear of loss of control over their own destiny as an individual or as an organisation. And so I think that's one of the things that we need to look out for. And I heard a really good saying last week from an ICB, which is about we need to align to a cause, not a camp. So this is about people from different organisations coming together around a common cause, rather than just coming at this from the what's in it for me / my organisation perspective.
Well, that's an excellent prompt then for what you've done or what you're doing in South East London, Andrew. I mean, you and Ruth actually recently appeared together on the Health Service Journal podcast, but that was before, I think, Andrew, you announced that your board had approved integrators in 4 of the 6 boroughs you cover, so Bexley, Lambeth, Lewisham and Southwark. I think you can now add to that list Bromley with the One Bromley partnership. So, I was fascinated when I heard that you'd done this just a few weeks, really, after the 10-year plan was published. So tell us how you've been able to make such fast progress in putting these kind of alliances together.
Okay, well, look, you're right on Bromley, just to say, and by the time we get to the end of September, Greenwich will be in possession of an integrator as well, so I'll talk a bit about them. And just to say, I'm the London League for Neighbourhoods. The integrated programme is a London-wide programme, and I expect that by the time we get to the Christmas, more than half the capital will have integrators in each of the boroughs, is the first thing to say. And secondly, I mean, we have started early, so we've not waited for the 10-year plan to tell us neighbourhoods are a good thing. So new Labour government, July, very clear broadcasting of the 3 shifts and a neighbourhood health service. And as I say, we're coming up to the anniversary of our first sort of work programme. Good to say, the first of our workshops, and we're delighted to have Ruth in attendance. We're also delighted to have Barts in the London, Imperial. We had Croydon Health, we had Guys and St Thomas's. We had a workshop about the out-of-hospital system with hospitals directly involved. And we've deliberately sought to build a consensus. So London has a target operating model published in May, but it was written in January, in truth. And January through May was making sure that we had a consensus or a single voice across London for what it had to say. The London-wide LMCs are signatories. The Mayor's office is a signatory. All of the ICBs across the capital and our councils, London councils that could go on. So in terms of what we are doing, integrators are 2 things. And the first is the formal agreement of all the providers, but I mean all of them, VCSE through to the largest foundation trust in the country, in related to a place to work together and coordinate the development and delivery of neighbourhood health in their patch across their respective neighbourhoods. So that's the first thing, and they do that through a partnership arrangement. And secondly, importantly, they, and we have approved it, that's right, but they have identified a host organisation with the heft to sort of provide some of the organisation there, both delivery, facilitation, providing infrastructure enablers. The interesting thing for me that unfortunately hasn't been reported on, but and I've got some speculation as to why, because it's not as exciting, is that all of our large organisations that have come forward, Guys St Thomas's, Oxley's, King's will be prominent in the Bromley system. They've only come forward if they've got a partnership with local general practice that's solid. So the detail of our press release is not to be missed. It's a partnership of the largest foundations in the country in each borough or place with local general practice to provide its integrated role. Now, we're not saying who's in charge. Yeah. We're saying who could help. That's what we're saying, who could help at the moment, because we've got fragility in our system. And because we've approached it that way, we think there's sort of 4 offers here, and they're really, really important. The first one is integrators are just practical. Okay, so we don't believe in a London borough the simultaneous delivery of neighbourhood care to populations by virtue of postcode at the same time as populated by virtue of condition in a complex environment with a multi-agency, multidisciplinary approach will just self-organise. They're just self-organised. We have structures. We think there should be some structure and people experience in providing that structure. So in each of our places, we've said, can he help us with that? We think it's enabling. So I am yet to meet the Director of Transformation for General Practice, or indeed the Chief Executive of General Practice, or something that provides the heft or infrastructure that allows, from my point of view, the gem of the health system being on general practice particularly. I know primary care is wider, let's talk about general practice. That clinical model doesn't necessarily need the back office arrangement it has at the moment. So can large organisations give of that, both in terms of back office, but also if I want ologists to come out into the community, wouldn't it be great if the organisation organising this were in charge of those ologists and say, well, that's part of your job plan now. So enabling. I think it's the best possible gold standard OD exercise we could have for the future. So I don't want to find out that hospitals don't particularly get on with general practice, who don't get on with councils at the point at which we let multi-neighbourhood contracts. I want to know that already and then be dealing with it. And so in these collaborative entities, we're encouraging absolutely the formation of entities that could hold contracts as a partnership. So we get away from that who's in charge bit. I'm the general practice or the federation or old school, go back far enough, fund holder, and I'm telling you what to do. And I'm not the acute, who's predatory telling you what to do. Can we work together? And finally, the bit that excites me most is away from the plan, but it's the opportunity. So I think there's a real opportunity if a Guys at St Thomas's or an Oxley's is providing the opportunity for general practice nurses who we struggle to recruit and retain to rotate through the system. And by the way, that would be a rotation through acutes, community, mental health, and primary care. I think that provides a career plan, and I'd be delighted to be in a position where we say we've got a Southwark nurse or a Lambeth nurse, and by the way, when they see you, they know the wider system. So there's an opportunity in workforce. I think there's opportunity in research and development, because we're going to have populations with the data sets right across health and care. And I could go on. The point being, the opportunity beyond just its holding of contracts, and dare I say it, beyond just neighbourhood health. They're not place-based partnerships. So we've got delivery vehicles here, and we are trying to provide the future entities that might be successful with neighbourhood or multi-neighbourhood contracts. And there's definitely a Londonness about them. So we've deliberately seen a London, and in our case, a South East London programme, because if they look wildly different in each borough, that's a considerable challenge, isn't it, for organisations like Guy's, who at any point in time would discharge substantively to 12 to 14 London boroughs each day, and each of those boroughs will have at least 3 and up to 7 or 8 neighbourhoods. So we can't do things differently unless it's good reason, but localism is important. Londoners have told us they want a core, consistent offer. And if you don't mind, a few things I expect to see off the back of this. Well, of course, I expect illness to be cured and all of those good trite things that I might say to you, but there's some pretty basics that we'd like to see. We'd like to see vulnerable residents who are currently turning up to GPs as patients because they've got a housing issue and they want a doctor's letter. That's their actual problem. And we'd like to have an integrator that might have organised things across housing, local government and the health service to say, well, actually, you don't need that letter and you can't afford that letter either, but we've created a system where no one can inform you of that. And so that's difficult. You want to be in a situation where you don't go to general practice to see a sign that says, at short notice, your practice is closed. We'll get back to you about where we can disperse this list, because we would have spotted that beforehand and put in the support across a partnership. Because in general practice in London, over the last 10 years, we've lost 20% of our practices. Now, some of them are amalgamated, but a lot of them have closed. So we do see the sort of fragility. And really importantly, I think if we perfect this, we'll get to the position where the housing officer has told the GP, we haven't seen Matthew for his early morning walk this morning. We're a bit worried about him. Can we have a look in? And really importantly, we'll have residents to say, actually, I'm part of a neighbourhood. I know where to get cheap food. I know what to do if I'm a bit concerned about my son's mental health. I know the club I can go to. So we've got an ambition for an integrator that can organise these things. There's a soft side to it, and then preparation for some of the things the plan has to offer.
I mean, Andrew, that is so fascinating, and there's so much I could talk to you for hours about that. But before we get into some of the questions I got about it, Ruth, when you listen to Andrew talking, obviously you're going around the country, for the Confed, visiting various places, trying to grasp the opportunities of the 10-year plan. What do you think other places need to learn from what Andrew is seeking to accomplish in London?
So I think firstly, what Andrew demonstrates is a really strong leadership from the top of the ICB. And I think that in some, I think that the leadership of this is not necessarily sitting at chief executive level, but, Andrew is really sort of embedded into this. And I think that's really important from a multi-organisation perspective. And again, I go back to the brokerage point about sort of seeing this being really driven from the top of the ICB. I think that, everywhere is different in terms of what general practice looks like. London's got its own fair share of challenges, as Andrew says. I think in other parts of the country where you've had primary care at scale working, and maybe the geography is smaller, then I think sort of the ability to bring primary care to the table, and I'm saying primary care in the widest sense of the word, is maybe a bit easier because they've got those historical working relationships, and in many cases they've already got those connections in with the local acute mental health or community. So I think that's one thing. I think in the sort of the ability to engage with trusts, I think, does look different around the country. Trusts have got their own problems, but from what I have seen a sea change over the last 6 to 8 months, where actually trusts want to get into this agenda. And, some people are cynical because it's like, well, of course they do, because they want to reduce their A&E attendances. But, as Andrew says, this isn't just about sort of A&E. This is about a much bigger issue around improving people's health and well-being, keeping them out of hospital, and addressing some of the more societal needs that they have. So from what I've seen, and I can only speak for the areas that I've seen, there is a genuine commitment from most trusts to work alongside general practice and other partners to get this right. And I think that's really heartening to see.
So Andrew, and I attended two events last week about neighbourhoods. One was the National Neighbourhood Development Programme, bringing together people from all over the country, 200 or so, and the other was this event I've spoken about in North Yorkshire and Humber. And there was a kind of interesting difference of emphasis. The first event very much kind of spoke to something we talk about a lot at the Confed, which is that neighbourhood working has got to be about a different model of care and a different relationship with communities. And so the table I was at, for example, there was one of the CHUIs, the care and health and care coordinators working in Westminster and other parts of the country, exemplifying a very different kind of way of working with communities. The event more locally, the North Yorkshire event, it felt it was more about the organisation of the health service around the kind of sustainability of primary care. How do we make sure we have both these concepts in mind when we work on neighbourhoods, that we have got to do things fundamentally differently? It is about people, it is about community engagement, but it's also about the nuts and bolts of how it is we reorganise things in the health service to achieve sustainability and better value for money.
Well, it's absolutely no surprise to me that you've got two things happening, and I tend to lean to where I see the biggest deficit. So I see the biggest deficit in that resident activation piece. I see the biggest deficit in us having models such as CHUIs in Westminster, but there are examples of those right across the capital. I know from other work in other parts of the country. So absolutely, that bit I think is a prize not to be missed. If I think about the social prescribing clinic that I attended in Peckham 3-4 months ago now, it is very clear from speaking to them, 90% of people are there with a housing issue of one form or another. If we look at any of the sort of local authority interactions with people in Lambeth, you become very, very aware that people have concern about fear of crime, loneliness, and actually, in fact, the health service and its response was 2 or 3 down the line. So I lean naturally towards that debate because I think it needs some voice. But look, we have to have a license to operate, undoubtedly, and we've got significant, really, really significant fragility in primary care, for example, in London. There's absolutely legitimacy to that. Where it's not particularly answer your question, Matthew, so apologies, but if I just overlay it with some of my own concerns, I am concerned that the metrics for the definition of success here will be very NHSE, if that's not E as the letter, but NHSE-Y. So I think we will look at how many admissions there have been. I think we will look at decompression of hospitals. It's a natural thing to do. It's important because it's a problem and it allows us to shift resources. I absolutely understand that. But I think there is an absolute priority of a slightly longer term prize around wider determinants of health. 20% of Londoners are economically inactive at the moment. I think we have a contribution that we can make to that. Housing, as I said, belies a number of the problems we've got. So how do we do both and how are we pursuing that? And so I'm concerned that the payback around neighbourhoods is expected to be very, very quick and fast. I think that's not to be unexpected, and it's not to be unexpected in the context we're in. So how does one manage both of those trade-offs? Pretty challenging, I would say. There is a willingness to do it, though, I think. So we talked a bit about South East London, but if I think about South London for a moment, we have a South London Listens Partnership, the full partnership throwing themselves into community engagement and solutions that will make a difference. There's room for it, but the reason you heard two different focuses is there are two. My worry is that overemphasis of one will lead us nowhere.
And can we talk a little bit, Andrew, about local government, but also about the kind of London dimension to this? So, you'll know that the Confed works closely with colleagues in local government. We advise local government leaders who want to grasp the potential of working better with health. I often feel that national policymakers don't really get local government quite often, and that's just the way Whitehall works, the way the silos of Whitehall work. It's really interesting that, throughout what you said to me today, you're talking a lot about local government. You're talking about the potential in areas like workforce we see with care and health coordinators of bringing together health and care workforce. I spoke to someone very senior recently who said, the potential for neighbourhood commissioning of social care is, that's something that we ought to be looking towards. So I think one of the things ICBs have had to do is they have a knowledge of local government that the centre often doesn't have, and create those relationships. But there are then particular challenges in London. I mean, if you look at what the 10-year plan seems to imply, how on earth do you have representation from every borough on ICBs? Obviously, the mayor has got a role here. So talk about the importance of local government in what you're doing, but also the particular challenges of the kind of politics of London. There have been tensions between Sadiq Khan and the boroughs, for example, and you're trying to work, in that space.
Okay. Well, Matthew, I don't assume too much knowledge of the South East London system, but I can tell you that the politics is quite different from inner and outer South East London, and has been for time and eternity, will continue. My experience of working with local government, and we do put a lot of emphasis on our local government relationships in South East London, has been very, very positive, largely because our local leaders, whether they are Conservative, Labour or other, and they are the two extremes in South East London, to be clear, and the sweet spot is local residents priority, and we are able to work across political boundaries pretty well in South East London. There's no magic dust on this, by the way. So if you look at my executive team at the moment, I have direct reports, a place executive, we call them, in each borough, who is a joint appointment with the local authority. They report to me, and they also report to the chief executive of that local authority. And we have that for each of the 6 boroughs. Because we have that individual is invested in the out of hospital budgetary spend, but also decision-making on adults, children and public health spend as well. And it's difficult to argue with yourself. So we've built in or baked into our ICB this idea of shared responsibility for health and well-being in each of our boroughs. And that was left us in very good stead. I'm worried, to be clear, that it's an apolitical statement, but the politicians and the shape of our South East London system and the London system that we're speaking to today may well change at the next election. Bromley has its first reform councillor 2-3 weeks ago. We anticipate that there may be some change in the capital. So I just make the point, the people that we speak to today, we've enjoyed a huge level of consistency. That may become different going forward. The mayor is a signature of the London target operating model, and it's been easy for us to come around the discussion around the health service, that particularly is even related to the growth agenda and to others. So in terms of tensions between the mayor and London councils, that hasn't impinged upon the plans that we have here. I should say, in terms of working with local government and understanding it, I'm completely with you. So the budgetary pressures on particularly children's services at the moment, on SEND, on housing, are severe and growing at a rate, and I've been working in the London system for 20 years now, that I've certainly not seen before. We have councils that are, I think, not able to offer anything close to the service that we were previously talked about when the last 10-year plan came around. So my experience is good. We've not suffered a dissonance. We have a mayor office fine up to what we are doing. But I think there is a changing political landscape, and we'll be aware of it. Just also to say, we're not in a position yet of bounding changes on local government in London. So when that comes again, perhaps we'll revisit this topic with you.
So Ruth, on this issue of local government, when I've seen, good neighbourhood practice, I remember one of the first visits actually I did when I arrived at the Confed 4 years ago was to Gloucestershire to look at their really interesting neighbourhood working. And one of the characteristics has been a strong relationship between primary care and local government. But that's highly variable around the country. And one of the things I've been kind of pondering on is whether we should be actually encouraging local government to step forward in terms of thinking about, the kind of stuff that Andrew has been doing, because, Andrew's got more stability with his ICB than many other ICBs that are moving, that changing their boundaries, that are going through enormous challenges, maybe don't have this kind of capacity for brokerage at a local level. So do you think that primary at scale and local government need to try to lean into each other at this stage and grasp the opportunity of thinking about different ways of organising things?
I think that's absolutely right. But I think there is, I think where there have been historical relationships, it works well. But I'm not as convinced there is as good an understanding of local government, how it works and the role it can play in all places around the country. And I think that, so we can certainly help with that. And that's one of the things we're doing in Confed, as you say, in terms of our work with local government leaders. I think the other bit is also, one of the things that worries me is the capacity in primary care to do everything that is expected of it in terms of keeping the show on the road and stepping forward to lead neighbourhood working and building all of those partnership relationships as well. And we haven't sort of invested in primary care leadership in maybe the way we have in other circumstances. So I think the desire is there to build those partnerships, and particularly with local government in the context of the neighbourhood agenda. And some areas have got that, and it works really well. And you can see it in terms of how they're delivering care and the join up between services. But I would say in other areas, there's quite a way to go. But it's not for a lack of desire. It's about capacity, but it's also about understanding.
Yeah, well, I completely agree with that. And we keep coming back to this capacity issue and the tendency always in the NHS to invest in bricks, but not to invest in cement or glue. How do you pull all this together? Because, as you say, if you're in primary care, there is an opportunity to really drive neighbourhood care, but it is going to involve leaning into local government, which people may have not that much knowledge or confidence of. It involves bringing acutes to the table. It's fascinating for me to see here in York the decision to appoint the former chief executive of the Acute Trust into the major at-scale primary provider. Really interesting move, I thought. I could talk to both of you for hours, but we're running out of time. But Andrew, it would be remiss of me not to just ask you, because you're part of our ICB network. Just your reflections on the process of ICB reorganisation that has taken place. I mean, there are enormous challenges around particular issues to do with redundancies. Things are slightly different where you are, but you must feel quite a lot of empathy for what your colleagues are going through, and also what your own staff are going through.
Completely right, and there are a few things that I think it would be really helpful if we could sort of cut to the chase on pretty quickly. But first to say, the plan is the right one. the execution we're really, really struggling with. And I say we in the broadest sense are struggling with. So the idea that strategic commissioning would drive population health resonates with me. The idea that a lot of the staff who work for me now will make an excellent contribution to a neighbourhood health provider of the future, or could work in joint commissioning, that really resonates with me. But the pace and the specificity of the plan isn't quite there. That really, really bluntly, it is very difficult out there. So the music does need to stop on some of this stuff now, to say there are some things we can secure today, but other things we have to work on for a bit longer. And so by trying to resolve everything, I think that creates some confusion. I think colleagues are becoming around that, but time is very short. We need to be much, much more realistic about what strategic commissioning is going to look like at the end of this first phase. So when the money stops, when we have 50% less to spend on the 1st of April 2026. Because at the moment, I know that £18.76, now £19, I know that's 50% of a bigger number. I don't know what a really good strategic commissioning outfit costs per head of population. We're doing that work now as we're undertaking this change. And then just straightforwardly, we do need a clarity on redundancy and the source of funds for that. And that, as you've alluded to, will be built differentially in different parts of the country. But just the avoidance of doubt, I have been ready to consult with my staff since the 4th of August. In truth, I probably could have consulted with them in the middle of July, and notwithstanding summer holidays, but we do not have a clarity around the source of funds for redundancy. And as I say, my issue with that is perhaps not as great as others are. Acknowledge that your empathy point is well made. I should also say, back to being the right plan, I have, for the last 3 years, shared 80% of my executive team, either with a local authority or with a provider in our patch. We have not had an HQ that is a standalone NHS body organisation. We have located ourselves in councils to rotate that money through the public sector. So our rent goes to a public sector body, and we don't incur costs we don't have to. And I should say, when one contemplates merger and cluster, there must be a really, really good population reason for it. We haven't in South East London. And I do feel for those people that are not only trying to shape the future and reorganise and merge, and do that with the level of uncertainty. So we need a sort of a bit of a stop break to say, this is what we're doing for now. This is the source of redundancy, and can people go ahead? And if I can consult at the end of this month, I still have the opportunity to realise a good part of our plan, but it becomes pretty risky after that.
Yes, and we're doing everything we can behind the scenes and now a little bit more publicly to try to press for a more realistic and reasonable response from the centre. Ruth, we're really out of time, but just on this issue for you, you've worked hard with primary leads in ICSs over some time, over in ICBs over some time. What's your kind of sense of how much kind of attention, how much span people have got in ICBs right now to be working with primary, given what ICBs are going through?
I mean, I think the interesting example is the application process for the National Neighbourhood Development Programme, where people have essentially had 4 weeks to get together applications from across their ICBs and submit them to the centre last week. And my worry about the timescales and doing it over the holidays was actually, given the turmoil in ICBs, particularly in those that are changing boundaries, have people got the capacity to do this whilst they're also applying for jobs, but worried about the future and it's holiday season, etc. But to be quite honest, I met with them last week and I've been completely amazed by the focus that people have had on this. And I think in some ways it's helped them to focus on something tangible that they know is the right thing to do. But equally, we've been having conversations about what does the future primary care function look like in ICBs? What size is it? What stays in the ICB? What could move to providers? And I think broadly, there's 80% agreement on sort of what stays within an ICB. But I think there is a real worry that we are potentially losing some of the posts around transformation, organisational development, GPIT, when actually so much of the plan, the cultural change, the structural changes that are needed require exactly that capability. So the question is, can we? I think it's Andrew's point about the transition is there a sort of a first phase of what it looks like whilst we build things up in provider land, outside of the ICB, and then a step 2. But obviously, that's all being worked through at the moment.
Well, look, thank you, Ruth. Thank you, Andrew, for sharing your thoughts with us today. Andrew, we must bring you back on again in a few months' time and hear more about the progress that you're making. If you, our listeners, want to share exciting or innovative work that you're involved in, then please do contact us. You might end up on Health on the Line. Contact healthcomsplus@nhsconfed.org. Thanks for listening. Goodbye.
You've been listening to Health on the Line, produced by Health Comms Plus. Health Comms Plus is a highly effective, innovative and creative communications agency brought to you by the NHS Confederation. We offer a creative, professional and cost-effective service for NHS and public sector organisations across the UK. Any profit we make is reinvested in the support we provide to NHS organisations and wider health and care systems.